most important intervention available to reduce the vertical transmission of HIV. With the best interventions available at present, the risk of transmission to mother to child can be reduced to 1 to 2%. Now Dr. Gloria Alexander, Director, ASHA Foundation, Bangalore, will talk on strategies for zero infection among the children. Over to Dr. Gloria Alexander.
Thank you. Good afternoon. The topic is strategies for zero HIV infections in children. As you all know, HIV positive children have been a tragic consequence of the HIV epidemic. And more than 90% of children who are HIV positive have got the infection from their mothers through mother-to-child transmission. Therefore, if we can prevent this mother-to-child transmission, then we could end up with elimination of pediatric HIV and zero infections in children. Coming to the problem, if you look at this slide which depicts HIV infections among children from 1990 to 2007, you can see that the numbers are very large. Even though there's some decrease in latter years, 2003, 4, 5, still the numbers are unacceptable. And the year 2008, 430,000 children were newly infected in the world with HIV. And more than 90% of them got it through MTCT. And without treatment, 50% of them will die by their second birthday. In 2009, 22 countries accounted for 90% of all pregnant women living with HIV who were in need of PMTCT services. India, Africa, and I've just outlined them for you below. This child, Sylvia Taylor, made this comment at one of the MDG goals meeting in New York in 2010. No child should be born with HIV. No child should be an orphan because of HIV. No child should die due to lack of access to treatment. Very poignant, I thought. WHO came up with a strategic vision for 5 years from 2010 to 2015, their vision being that women and children should be alive and free of HIV. The goal was to eliminate pediatric HIV infections and improve maternal, newborn, and child health outcomes in the context of HIV. The objectives were to accelerate the global and national scale-up, to improve the quality and demonstrate the public health impact of PMTCT, and to strengthen linkages between maternal, newborn, child health services, reproductive health services, and sexual health services. In 2011, UNAIDS came up with a global plan. The goal was, and this focused actually on those 22 countries which accounted for 90% of all PMTCT, of all MTCTs. The goal of the global plan was to move towards eliminating new HIV infections among children by 2015 and keeping their mothers alive. The two global targets were, one, to reduce the number of new childhood infections by 90% by 2015, and to reduce the number of HIV-related maternal deaths by 50%. They had 6 key conditions which they put down: that all women should have, especially pregnant women, should have access to quality life-saving drugs. The rights of women should be considered. Adequate resources, both human and financial, should be available. HIV should be integrated with maternal, child health, and reproductive sexual health. Communities, in particular women living with HIV, should be enabled and empowered. And all leaders, national and global, should act together. At the same time, WHO came up with 7 strategic directions for PMTCT. 1 was commitment, 2 was to provide technical guidance, 3, as I've kept saying, to integrate it with other health services, to provide equal access to all women, to promote and support the health systems, to measure progress, and to collaborate between regional, country, and global partnerships. The 4 prongs of PMTCT which came out by UNICEF, which were brought out by UNICEF way back in the early 2000s, still remains the backbone of services for PMTCT. Primary prevention of HIV infection among women of childbearing age, preventing unintended pregnancies among women living with HIV, preventing HIV transmission from a pregnant HIV-positive mother to a child, and then providing treatment for that mother and her children and the family so that they could all live longer and together. These are the 4 prongs that we talked about. This slide actually gives you the connection between the global targets of the global plan and the 4 prongs. So by reducing the HIV incidence in women of reproductive age group, and by reducing the need for unintended pregnancies, by providing mother-to-child transmission, by preventing mother-to-child transmission of HIV, you could reduce the number of new HIV infections among the children. And then, by providing treatment for the mother, not only during her pregnancy, but lifelong, you could reduce the number of AIDS-related maternal deaths by 50%. This slide actually shows the financial investment that is required for something so huge. It's in billions of dollars. This is for those 22 priority countries. There was an expense of about $1.3 billion. I like the detail in this slide and how they divide the costs for different aspects of the cascade of services, like family planning, HIV testing and counseling, the treatment, the investigation, CD4 counts, the co-trimoxazole for the mothers, community mobilization, ART for the infants, early infant diagnosis, and co-trimoxazole for the infants. In 2015, UNAIDS came up with the progress that had happened to their global plan, which they started in 2011. And they found that in 2014, they had 170 new infections in children. Considering that in 2008, it was 430,000, there was a significant reduction in new HIV infections by almost 48%. And out of the women who were diagnosed HIV positive, 8 out of 10, that is almost 80%, did receive treatment. And the risk of transmission, which is between 20 to 45%, had been reduced to 14%. Now, these reports are only for those 21 countries. India is not part of this in the report. The percentage of new declines in HIV infections, there was more than 60% decline in these countries with the green bar, 30 to 60% decline in the countries with the orange, and less than 30 in countries with the red bar. So you can see that South Africa did fairly well, 76% decline in new infections in children. This shows the percentage of pregnant mother receiving ART according to country. And here again, you can see that South Africa, Swaziland, etc. are doing quite well, whereas countries like Chad and Nigeria were not so good. India, again, is not part of this. AIDS-related deaths from 2009 to 2014 have come down by almost half in women of reproductive age group. Percentage of women receiving treatment has gone up, especially from 2012. And children receiving ART prophylaxis or ARV has also gone up. Now, recently we've been hearing this word EMTCT, elimination of mother-to-child transmission of HIV. This WHO brought out the criteria to validate a country as having eliminated mother-to-child transmission. There are 2 impact targets and 4 process targets. The 2 impact targets are that for HIV, there should be less than 50 new pediatric infections per 100,000 live births, and a transmission rate of less than 5% in breastfeeding and less than 2% in non-breastfeeding populations. For syphilis, it was less than 50 cases of congenital syphilis per 100,000 live births. And the 4 process targets are shown here. Antenatal care coverage of more than 95%, HIV testing of more than 95%, antiretroviral coverage more than 90%, and treatment of syphilis and seropositive pregnant women of more than 95%. Now, Cuba was the first country which was validated by WHO for elimination of mother-to-child transmission and congenital syphilis in June 2015. This is surprising because Cuba is a country of limited economic resources, ranking 114th of 230 countries on the Global Economic Indicator of Gross Domestic Product. But its success was because of its strong primary healthcare infrastructure, its fantastic health systems, large cadre of well-trained doctors and nurses, and they were providing basal healthcare services free of charge. Their data monitoring system was also excellent. They also had evidence-based clinical services, surveillance data monitoring, program evaluation, and continuous feedback, all of which contributed to them being able to eliminate mother-to-child transmission. Thailand was the second country that was validated for elimination of mother-to-child transmission as in June 2016. It was the first country in the Asia-Pacific region to do so. And this is because they always had very strong HIV prevention services. They were able to integrate the whole thing. And 90% of all pregnant women living with HIV had access to ART, and the mother-to-child transmission was less than 2%. In 2015, the number of children who became infected with HIV was reduced to 85, a decline of more than 90%. Where are we with India? Women account for 40.5% of all infections, children account for 6.5% of all infections, and in 2015 we had 86,000 new infections. Of course, there was a decline compared to 2000 and 2007, and out of this 86,000 new infections, about 10,500 were in children. So if you look at the adult HIV prevalence, this is according to the estimates of 2015, there is a decrease if you look at the orange line in the seroprevalence. Estimated new HIV infections from 1998 to 2015 are showing a decreasing trend. Annual AIDS-related deaths are coming down, ART coverage is going up. In 2015, they estimated that there were 35,000 HIV-positive pregnant women requiring PPT-CT. In 2012-13, they were able to detect about 13,443, so maybe around 1/3 of this group. Around 10,500 children were positive at 30% MTCT in 2015. PPT-CT needs from 52,800 in 2007 reduced to 35,000 in 2015. And 12 states account for 88% of all PPT-C needs in the country. Our PPT services began in 2002. We have 18,000 ICTCs. We used to give single-dose nevirapine for almost a decade. The risk of transmission reduced to 10%, but was not enough. And then the 3-drug regime started in 2012 and has been upscaled. So the goal and objectives of PPT services in India, same vision, women and children alive and free, goal to work towards elimination of pediatric HIV and improve maternal, newborn, and child health outcomes, to detect more than 80% of HIV-infected women in India, to provide services to more than 90% of the detected women, to provide EID to more than 90% of HIV-exposed infants, to ensure access to ART to 100% HIV-exposed infants, ART or ARV, and to ensure more than 95% compliance with ART in HIV-infected pregnant women and children. So the latest guideline is that all HIV-positive women, irrespective of CD4 count or clinical stage, should be started on 3-drug ART, and all HIV-exposed infants should receive at least 6 weeks of nevirapine syrup, but should be increased to 12 if the mother has received less than 24 weeks of ART in exclusive breastfeeding. Advantage of this is that it's easy to give. It is harmonized with the ART regime for adults. Increased coverage of ART, you don't have to worry about CD4 count and clinical staging. And of course, it will decrease MTCT. It'll increase the lifespan of the mother. It's acceptable to everybody, including the communities, and it prevents transmission to the sexual partner. I just put up this slide because I felt it showed the depth of detail that the government of NACP is doing to detect how many HIV positives there are in each state, what percentage contributes to the overall India load, how many of those districts have been given priority, and how many they have been detected out of how many that are estimated. So if you look at the total, there's 38,204, out of which 15,000 have been detected. So we still have a fairly long way to go. What are our challenges? Only 70% of estimated pregnant women access antenatal services nationally, 60% only are institutional, 30% do not even know their status, and we have a concentrated epidemic, so services are concentrated in these districts. Strategies, I've listed them all out: political commitment, scale up services, we need commitment along all cascades of PMTCT services, integration, effective surveillance, supervision, monitoring, effective tracking and measuring outcomes, talks, public-private partnership, empowerment of women, community development. These are children born to HIV-negative children, born to HIV-positive mothers. These are the future citizens of our country, and it's our duty to prevent them from getting disease and to be healthy. Thank you.
For an excellent presentation, narrating different strategies in curb the HIV infection in the newborn. Now, we move on to the last talk in this session, managing HIV